Good morning, everyone. This is Mark Erkin, and I want to again welcome you to our Friday morning virtual journal club. We've got a really tremendous lineup this morning, and the presentation of this article on anaplastic thyroid cancer comes at, there couldn't be a more appropriate time in light of the recent guidelines that were published by the American Thyroid Association. And so this is incredibly timely, and we have truly outstanding presenters this morning. It's really a pleasure for me to introduce Dr. Nancy Lee, who is a very respected colleague in radiation oncology. I've had the tremendous pleasure of collaborating with Nancy in the care of many patients over probably the course of a decade. Her expertise is always on display, regardless of the challenge of dealing with either virgin head and neck cancer patients or patients who have recurred. And so I want to publicly thank her for all of the work that goes into the care of mutual patients. As well as I'm sure just an incredible number of patients who have benefited from her care over the years. Nancy is currently the Vice Chair of the Department of Radiation Oncology and Chief of Head and Neck Radiation Oncology, as well as the co-leader of the Head and Neck Disease Management Team at Memorial. She's also the Service Chief for Proton Therapy. And just to give you a quick update, she migrated, I believe, from the East Coast out to to UCSF, where she received much of her training, moved back to New York, and joined the faculty at Memorial, where she currently resides. In addition to holding numerous NIH R01 grants, she has also published over 250 peer-reviewed publications and is the editor of several textbooks. Her expertise in advanced thyroid cancer management is well documented. She's played a critical role in defining the role of external beam radiation therapy in this disease. Our discussant today is Ashish Chintakuntlawar, and I apologize for that pronunciation. He is an associate professor of oncology at the Mayo Clinic College of Medicine. He received his medical degree at the Grant Medical College in Mumbai, and then completed his PhD at the University of Oklahoma, and then went on to a postdoctoral fellowship at Harvard Medical School before moving on to do his residency at the University of Arkansas, followed by a fellowship in hematology and oncology at the Mayo Clinic, where he currently is on the faculty. Ashish is widely respected for his expertise in medical oncology in advanced thyroid cancer. He is a most appropriate and highly qualified expert to discuss today's presentation on anaplastic thyroid cancer. And before I turn over the podium to Nancy, I just want to give a quick update. I've been talking about changes in our Friday morning programming, and these will be rolled out over the coming months. We will be running a thyroid tumor board, which will be a multidisciplinary discussion once every 2 months. Our first one will be at the end of April, and Mike Tuttle is going to be leading that discussion. And then we'll be doing challenging case presentations, and expect that hopefully our attendees from all over the world will send in their challenging cases, and if they do have cases they'd like to present at Thyroid Tumor Board, we will certainly provide a template for the information, the imaging, etc., that we would need in order to present those. We'll send out more information regarding that. As always, I'd like to encourage all of you to send in your questions. We're going to try to have time at the very end to get to those. So with that, thank you everybody for joining us. And Nancy, I'm going to turn this over to you.
Okay, thank you, Mark, and I just want to thank Dr. Erkin for inviting me. And I really enjoy working with Dr. Erkin. He's one of the best head and neck surgeon I've ever met, and he does his own free flap too. It's just wonderful, and I love that relationship. And thank you for having me to talk about this paper on anaplastic thyroid cancer. And these are my disclosures. I'm just mainly on the ad board, and I have some funding to run some of the clinical trials. So when I think of thyroid cancer, I think of it as a continuum. As we know, there's the classic papillary, tall cell variant, to moderately differentiated, to poorly differentiated, and then frank anaplastic thyroid cancer. And today we will be talking about anaplastic thyroid cancer. And then, when you think of anaplastic thyroid cancer, it comes in multiple different flavors. They're the ones that where the surgeon operate, and then in the midst of papillary thyroid cancer, tall cell variant, inevitably the pathologist finds anaplastic cells, and therefore those are the patients that do the best because you took out the tumor and then you're giving adjuvant therapy. And then there are the patients where they kept recurring, finally turns into anaplastic thyroid cancer. And they do moderately well because you still have surgery as an option. And then there's the de novo presentation where, the patient is totally fine, otherwise living healthily, and one day wake up, the neck blew up like a golf ball or a grapefruit. And then those are the ones that we worry. Until recently, I have yet to see one person cured from these de novo cases, but very exciting data, which I'll allude to a little bit later. So anaplastic thyroid cancer, as we know, is very rare and aggressive with a dismal prognosis, especially those that have de novo presentation I just spoke about. It's about 1 to 2% of all thyroid cancer and accounts for 50% of the cancer mortality. The median survival is less than 6 months, and with 1 year survival around 20, maybe 30%. And greater than 50% of the patients already present with distant metastases. So it's important to work up your patient, which I'll allude to a little bit later about our paper. And then there's limited randomized controlled trial on this setting. Nonetheless, we did try, which I'll show you as well. So as you see, especially the 4C disease patients with distant metastases on presentation, they're just dismal. They don't do well. And then, but not to give up. And this is why I think that in select cases, surgery still play a role despite having distant metastases. And now with the whole targeted therapy, it really changed how we think about this disease, which I will get into later as well. Now, the morbidity of ATC is really due to the local regional disease because rather than distant metastases, because there are numerous critical structures and they're located near the thyroid, such as the esophagus and the trachea. So these tumors will invade these structures and cause asphyxiation, upper airway compromise. So in my mind, when I think of these cases, my goal is to control the local regional disease. I know the patient may have distant metastases, but let me control that so that somehow if the patient and when the patient do die, it's not dying from a horrible local, uncontrolled local regional disease. I think surgery is important in the equation. And one study even showed that if you can operate, the median overall survival is 22 months versus 6.5 months. And it makes sense, right? The people that are operable tend to have a little bit less advanced disease compared to inoperable cases. And that's where surgery plays a major role. So there's some selection there, although again, the targeted therapy, which I'll get into, really changed some of our thinking. That's very recent, like within the last couple of months. So importance of local regional control, as I said. And then the goal for me is really change the pattern of death from uncontrolled local regional disease to distant metastasis disease if the patient ultimately succumb to the disease. So importance of local regional control. And so in the metastatic setting, we know the median overall survival is about 4 months. 1 year overall survival is really poor, 9 months. There are some people that can survive, and there are different cocktails have been used. And I think, as Mark said, there's a recent ATA guideline. And different agent, different systemic agent. Adriamycin is probably used most frequently, Paxil, the Taxol, and I think Ashish will get into that as well. And then there's platinum-based, and then there's, in the past, we had limited activity with the multi-kinase angiogenesis inhibitor, TKIs, and there's nothing that really worked well until recently. If your tumor, and the first and foremost in our mind is if you have ATA, get the BRAF status. If you're BRAF positive, you can be treated with TKIs of dabrafenib and trametinib, and that has shown tremendous promise, which I'll show you an example later. So that has changed and altered our thinking. So everyone that walks in our door, the first thing we get is the BRAF status, and then we have a whole diagram, which I'll get into in a second. Okay, so now I did want to talk about this study because Keith Bible and Eric Strum and I, we, based on their work from Mayo Clinic, at the time, 2009, we put the concept together in 2007, where this is the first cooperative study on anaplastic thyroid cancer. And remember, I said that there's limited randomized control study, and it was amazing that the group, RTOG, can actually get together and do this phase 2 randomized study, the first ever cooperative study, multi-institution, and also randomized. And the idea here is to give this new TKI, multi-targeted TKI, pasatinib, and there's activity from Mayo Clinic, and then combining with Taxol for anaplastic thyroid cancer. And here, we didn't care at the time whether they're M0, whether they presented with no distant metastases or they presented with distant metastases. And patients had a leading phase as the radiation oncologist is planning the radiation. The medical oncologist can give Taxol with placebo or Taxol with pasatinib. And then we start the radiation, preferably with IMRT, although we did allow 3D conformal radiation therapy, and 66 gray, and then with Taxol or with placebo or Taxol and pasatinib. And then our objective was to see the 1-year overall survival. And I wanted to report this because this data just was presented at ASCO, and Eric already put together the paper, and it will be in the near range to submit. And what's interesting is though it didn't reach significant P of 0.2, you can see the curve is separate. So it's quite promising. So now we're going to think about the next phase and how to integrate that with the newer dabrafenib and trametinib for this disease. So I wanted to just give you background. So cooperative study is possible even with anaplastic thyroid cancer. So that's the conclusion. Okay, so now about the journal club. This was what a joy for me to put together this paper. You can see the years that expand, 1984 to 2017. Our radiation technique has changed, which I'll go into in a second, and then even our thinking process had changed. And so, and even our pathology has changed. So if you will recall, in 1989 at a Sloan Kettering, we had published this paper where it was unbelievable anaplastic thyroid cancer result where the 2-year survival is like in the 60% range. And it's like nobody else can in the world can reproduce. And we were like, what's going on? So what we did, in the, I came to Sloan in 2003, about 2008 or so, Eric and I said, you know what, let us go back and get the tissue. Let's go back and look at whether these patients are truly anaplastic thyroid cancer or they're actually poorly differentiated carcinoma that look like anaplastic thyroid cancer. So we did, and our pathologist, Ronnie Gosin, went back and reviewed all the slides, and turned out that the original paper we published in 1989, a whole bunch of them are not even anaplastic thyroid cancer. So that explains why the prognosis or the survival was so great. So for this particular paper, we are very, very big on looking at the pathologists, making sure from 1984 to 2017, they were all re-reviewed or they are just truly anaplastic thyroid cancer. And Ronnie Gosin is our pathologist, and he went back and then looked at every single one of the paper, the slides. And so spanning this large range, 104 patients. So because we took out all the poorly differentiated, so strictly 104 that had radiation as sloan. So we didn't account for people that didn't have radiation here because I didn't have all the records. So we want to have a uniform consecutive group of patients that had disease here as sloan, and not everybody has surgery as sloan, but we are sure to say everybody had radiation as sloan. And so medium range about 60-ish, male, female breakdown about 50-50. And you can see majority of patients were stage 4B disease, but there was quite a bit of 4C, the people that present with distant metastasis, about 22%. And the median, they're quite big tumors. Some people are about 17.8 centimeter. And there is some coexistence with differentiated thyroid, but there was that anaplastic component, so which is important when we talk about the importance of surgery. Now, tracheostomy tube is generally, like when you think about Frank de Novo, our surgeons hardly ever put in trach, because as you insert the trach in, you can see the tumor can come out of the trach. So, but nonetheless, in the patients that did have surgery and some people that needed the trach, we did have about 12% of the patients that needing trach. And you can see patients often had extra thyroidal extension and often had microscopic tumor before radiation. And then when we come to this side, that I wanted to say that distant metastases about 22%, before RT about 30%. So even though there was distant metastases, at least when I joined, it wasn't like, oh, I'm just going to give some palliative radiation. Absolutely not. If you're going to beam on, you have to give a good, healthy dose of radiation. Otherwise, we have shown that it didn't improve the local regional control or improve patients' overall survival. And you can see there's the R2 resection, R1 resection, R0 resection. We were able to have R0 resection. And typically, these are the people not typically the de novo presentation. Look at the median dose, okay? So you can see 1984, some people only had 600 or 6 gray to 7,000. I joined Sloan at 2003. And at that time, we brought in IMRT, and IMRT allowed us to dose better without hurting the spinal cord, which I'll show you a picture in a second. So that's why you can see the dose in a later year, and you'll see in the paper after 2002, we kind of had like before 2002 with the kind of older radiation, less dose radiation, to after 2002 or 2003 beyond, we typically gave 66 to 7,000 centigrade. We gave almost always with concurrent adriamycin, usually 10 milligram per meter square, where sometimes even up to 20 milligram per meter square. We did do some taxane-based, especially if they were protocol. And 51% had trimodal, meaning surgery, radiation, and chemotherapy. And that's really our patient characteristic. And median follow-up for the entire cohort is about 6 months. And then surviving patients about almost 11 months. And I wanted to point this out because stage 4A, B, and C disease, you can see that 4A typically we treated with surgery, radiation, chemotherapy. Stage 4B, 55% had trimodality, 42% only was able to get chemo radiation as they were unresectable. We always went to surgery first, and about 2% only just had RT alone because of multiple comorbidities and age. Now, interestingly, in 4C disease, among about 30 patients, 26% still, when we can have surgery, we went for surgery, despite having distant metastases. This is the importance of when we bring in local regional control, having trimodality therapy is always better than not having surgery as a component. And you can see 60%, 61% had concurrent chemo radiation, 13% were treated with radiation alone. And interestingly, those that did have surgery among the 4C disease, the median survival was the 6 patients, 4 months versus 2.8 months. So you can see that we were able to bump up the median survival and overall survival for these patients. And here's the curve. So when we look, excuse me, When we look at overall local regional control, it's about 60%. And when we looked at the multivariate analysis, it was the trimodal therapy, meaning surgery as a component, and chemotherapy, and greater than 60 gray. And this is what I mean. If you're going to give radiation, don't give something like 30 gray in 10, which is a typical palliative dose for anaplastic thyroid. And it's so tempting when the patient had distant metastases, why subject them to a 60 gray radiation? It's because, remember, we want to alter the pattern of death. You want to give an enhanced local regional control. And when we did trimodal therapy, you can see the curve separated 80%, almost 80% local regional control versus about 20%. And then even dose. Look at this. If you gave 60 gray or higher, this is our curve. Meaning we were able to control local regionally and not have an uncontrolled situation, versus if you gave like very low dose of radiation, you can see it's not as easy to control the disease. So again, I cannot stress the importance of having high dose of radiation despite 4C metastatic disease. And then we did multivariate analysis, univariate analysis, but most important again is what I said, the dose and the importance of surgery. And how about overall survival? You can see that, again, if you had trimodal disease, the local regional control translated into improvement of overall survival. So it's not just we're controlling local regionally, but we're actually improving their overall survival. And people that didn't have the trimodal disease, you can see their dismal outcome. And even also with the importance of dose, when we have radiation high doses, we were able to keep the patient alive longer than if they didn't have greater than 60 gray of radiation. And then when you look at the, again, multivariate analysis, that what's important here is whether they had distant metastases at presentation. And I want to call your attention here. This is the overall survival of the entire cohort. And look at how it parallels distant metastases-free survival parallels. So ultimately, these patients do die. You do everything you can to prevent it as a local regional death. It can improve survival, but they ultimately, if they do die, it's paralleling to distant metastases rate. And then what I wanted to emphasize is people that presented with distant metastases, they didn't do as well as those that did well. They didn't have M1 disease, and then as you follow them longer, they ultimately develop M1 disease. M1 disease. So those patients that better than that didn't have pre-radiation, they're M0 versus that had M1 disease, and that makes sense, right? And the thing about ATAs, there's M1, there's M1. And now it's really interesting for me. I would never think about giving like high doses like SBRT. SBRT, just for the non-radiation oncologists, is stereotactic body radiation therapy. We give very high dose of radiation, like 9 gray times 3 to like a bone met, or like 10 gray times 5. So I would never think doing that for AT anaplastic thyroid, especially de novo. And guess what? We're doing that because we're keeping them alive longer. And now I do spot radiation to distant regions. Okay, so this is important. I want to talk about the evolution of radiation technique. So as a radiation oncologist, I think about targeting. I think of almost like how Dr. Erkin thinks. I think where he went, where he found it was important, and that would be my target, along with a margin. And even if I am not, if the surgery is not a component of this patient's care, I'll think about patterns of spread. What would the surgeon have done? So we think of the thyroid, we think lymphatic rich, central compartment versus the lateral neck, right? And then here, level 6, and here, particularly important is this TE groove here, very important. And I've learned over the years that, for non-anaplastic, we can be fancy, we can omit the lateral neck, we can just treat the central neck, and I think ATA as well. And then we may be even fancier for fancier with non-ATA to just treat one side, but for anaplastic thyroid cancer, very important that we get the entire central neck. Just because you have no disease on the contralateral side doesn't mean you don't get it. You don't treat. You have to treat both sides because it's very lymphatic rich and making sure just get the entire central neck so you don't wind up having issue down the road and get to level 6. Okay, this is the old radiation technique. This was actually part of my training in the 1990s where, you know, in order to treat the thyroid, which is located right here, we have to go through front and back. We call this APPA technique, right? APPA technique. And what you see here is that you have your spinal cord here, right? Here's the spinal cord. You go front and you go back. And you got a big thyroid mass here. You want to give this dose, but you can't because you're limited by the spinal cord, which the tolerance is about 45 to 50. That's why you see a lot of the literature says 50 gray, 45 to 50, because they're limited. And then you can use electrons, different ways to target, but electron doesn't go that deep. So you wind up not being able to deliver a good dose of radiation. And then you may say, why don't I try lateral beams, right? So then we can protect the spinal cord. But the problem is you got the shoulder. You're not going to treat through the shoulder. So this is one of the limitations, spinal cord and shoulder in the way. So you're kind of stuck with a dose of 50. Now, with IMRT, beautiful. Look at this tumor. You can now treat this red color tumor to 70 gray, right here, 70. This is sagittal, axial, and coronal view. But look at the spinal cord. Blue color here, 45 gray. We can dose 70, and by the time you get to the spinal cord, in fact, it's outside of the 45 gray range. So that's why if you look at newer studies, radiation, you'll see higher dose. It's because now our radiation technique changed. We're able to treat and give that greater than 60 gray dose. So if I'm going to dose it, I usually tend to get it to 66 to 70 gray because I don't want any recurrence local regionally and change again, you know, that prevent any uncontrolled local regional issue. And then make sure you treat both sides of the central neck. You can omit, for example, the lateral neck if it's not important, or even the upper neck, so that you can limit some of the toxicity that patient experience looking at the case. And then over the years, you know, I will, if I only have disease on one side, I can tailor-made my target, which is just in yellow, and then sometimes important to get down to the upper mediastinum, depending on the case. And this way I can spare the parotid gland, the oral cavity, so they really just have esophageal issues. And here, this is what I mean by for, ATC, you can see that it's important to get both sides. Whereas for papillary thyroid, this is my target. I just treat where, for example, Dr. Ergen says, Nancy, I'm very concerned about this region of the TE group. I will omit the lateral neck because he can always go back. And this way, we get the best of both worlds, meaning that we limit the dose. And this is for non-anaplastic thyroid cancer, ATC, sorry. Okay, so how about toxicity? What's the price to pay? So you may say, well, 60 gray is a lot of radiation. You're gonna just really a lot of toxicity. Well, so over the years, we did see toxicity, no question. And a lot of, you know, this is the baseline. You can see at 3 months, you can see that dermatitis, adriamycin can cause dermatitis. Someone really wicked grade 3 dermatitis with adria and radiation combination. And then there's people with dysphagia. Just about everyone has some type of dysphagia, no voice changes. And then here, subacute, they continue to suffer, and then even some late toxicity. So this is where I say, you know, what can we do if we limit the field of radiation? Then our dose here, our late toxicity can be less. Because think about it, remember this is the evolution from 1984 to 2017, our RT technique changed. So this is a conglomerate of toxicity. So in the newer days, really we see some acute toxicities and even maybe some acute, subacute, and then ultimately they just really go back functioning. My goal is really trying the best to not even have a feeding tube. Because, you know, I want them to be able to eat and swallow, so at least they can have some sense of quality of life and not just be stuck with a peg and a tray. That's just horrible living. So the one thing is, this is actually from another paper, non-ATC. So I wanted to just show that people do recover. This is the patient-reported outcome. We are going to write a new phase 2 protocol for anaplastic thyroid cancer, where we're going to also track the patient-reported outcome. The good thing is people do go back to almost like their baseline. So now I want to end with this. This is the latest hot where we really had to change our entire practice for ATC at Sloan. Importance of genetic testing. We had 32 patients in our 104 patient where they underwent impact testing. And we found, 50% had P53 mutation, about half had TERT mutation, not surprising. About 40% had BRAF mutation, 19% P10. And during this cohort, we had people that were treated with venurafenib or dabrafenib and trametinib, different combinations. And one patient was even given everolimus based on P10 status. These are all targeted TKIs or BRAF, targeting BRAF. And what's interesting is that the overall survival in this population median was quite high compared to the traditional, what we think of, dismal median survival. So this was a hint. We're thinking, this is interesting, right? And here's an example. And then, so as we look at this, it's not the topic of today, but there was a recent paper out of JAMA Oncology from MD Anderson, where they do have they use dabrafenib and trametinib for their V16E BRAF positive anaplastic thyroid cancer. So I wanted to say that my patient, this is a patient of mine, she's, otherwise super healthy in her, late 60s. She presented one day with a big balloon in the neck, and back in April 19, sorry, it's ATC, April 19, 2019. And when we see this, this was a time when we just switched from sort of a patient like this. What I would do is APPA, start radiation, quasha, palliative, quickly, because it's not a surgery candidate, and then we'll switch to fractionated. We have the control, chemo, radiation. But now, again, our big practice is we biopsy, we do genetic testing. It turned out that she had a BRAF positive mutation. So she was on this drug for over 1 year, and you can see dramatic response. Mind you, she also had distant metastases, and we clear all the distant metastases. So remember, April 2019, we're now she's still alive. This is almost 2 years now. She's still my patient. She has surgery around. So after you give your BRAF and targeted therapy, dabrafenib and trametinib, you get to a point where the response is maximal. We actually ask the surgeon to go back and operate and follow the MD Anderson paradigm. And then after she was operated, the next thing we do is obtain local region control. Surgeons still find sticky, very stuck to area. Don't let the imaging fool you. It's like there's still disease. So she had her surgery in October 2020, and then we follow with something called quasha radiation. And the reason is that we want to get them back to dabrafenib and trametinib. And she finished her quasha radiation, which is twice a day for 2 days for about 3 cycles. And then in between cycles, we give drug and chemotherapy. And then what's interesting is she developed an isolated lung met. And now I am giving her high dose SBRT to that lung met. She's clear of disease everywhere else. And she's 2 years out from a de novo presentation. That's crazy. It's mind boggling. So this is quasha radiation. We just treat the disease with a margin twice a day for 2 days at 3.7 BID. We wait about 3 weeks, not 3 to 6 weeks. Sometimes we have to, depending if we want to give the drug in between. We repeat this about 3 cycles. So it allows the medical oncologist to do the systemic therapy so that you're not fractionating 6 weeks in our department where then you're stuck with Adriamycin. So this is the, Mark, this is the paradigm. We spent all day. It's really complex. Just want to tell you, if one thing I leave with you, do your genetic testing. Once you finish your genetic testing, BRAF positive, you try to give your drug. If you're still able to, and then if you're able to operate. If not, go to chemo radiation route. Some selected cases fractionated, but I'm really thinking this quasi radiation because allow them to give systemic therapy in between cycles. So where, remember, they can have distant metastases. So we're actually putting together that protocol, Mike Tuttle, myself, and Eric Sturman. So that's what I want to leave you with. So in conclusion, survival ATC, sorry, I don't know why I keep writing ATA because I think I'm thinking American Thyroid Association, but anyway, ATC seem to be improving compared to historical control. Importance of if you're going to beam on dose and also trimodality therapy, aggressive RT should be strongly considered, but most important, get your genetic testing, give your 2 drug, and then follow an algorithm. If you can operate, followed by radiation chemotherapy, and then restart the TKIs immediately. And there are people that are still living beyond 2 years on de novo presentation. That's just mind-boggling. We're still following them. And thank you for your attention. Okay. And Ashish, I think, will be speaking. Yep.
I want to make sure you're saying the right slide.
Yes.
Okay, thank you for the invitation. Thank you, Nancy, for that wonderful talk. It's quite inspiring. Thank you all for your attention as well. And my name is Ashish Chintakuntlawar. I do medical oncology here at Mayo Clinic and work mostly in head and neck tumors. I'm gonna go ahead and talk, these are my disclosures, and talk briefly about Dr. Lee's paper and then spend some time on the latest advances that Dr. Lee touched upon. I think this is a phenomenal paper. This is the question that Dr. Lee's group is asking is, can we improve upon overall survival for this dismal disease? And I think the answer is a resounding yes. With chemoradiation in their cohort, the median overall survival was close to 7 months, and about 34% of patients were alive at 1 year. Comparing that to some population databases like NCDB or SEER, the median survival for the whole cohort is close to 2.2 months. Of course, there are certain caveats to comparing these, but I think we can resoundingly say that with chemoradiation, we are probably saving people. The question is, who is a candidate for chemoradiation? And as we speak, I think that is changing compared to what we do today. Like Dr. Lee said, 3 years ago, we here at Mayo, we were probably giving chemoradiation to almost everyone, including stage 4C disease, but that paradigm is changing with genetic or targeted therapies. This is one of the largest cohorts of triplet therapy, if not the largest. They have given curative radiation to almost 100 patients, and out of them, 53% of the patients have had undergone surgical resection. Very importantly, what we can learn from this paper is multimodal therapy results in excellent local regional control. This has been shown in multiple papers, but it was nice to see that you can do that in the context of patients who have not undergone surgery as well. If you look at the multivariable analysis, there were 2 factors that were important. One was the trimodal therapy, and the second one was the residual disease or patients with macroscopic disease in the neck. One other thing that comes up every so often almost once a year is patient has undergone surgery for differentiated thyroid cancer, and the pathologist calls back and says, hey, there is 1 centimeter focus of anaplastic thyroid cancer. What should we do now? And we have always proposed doing adjuvant chemoradiation, and sometimes we are questioned as to why we need to do that when we have a 0.5 centimeter or a 1 centimeter anaplastic thyroid cancer focus. And the answer from this manuscript is very clear. They had 5 patients with stage 4A, and more than half of the patients developed recurrence. And in any disease, when you have that high of a risk of recurrence, I think adjuvant therapy is a must. So I think we can definitely say chemoradiation more than 60 gray or 66 gray is the cornerstone for ATC therapy, and we of course should include surgery in this paradigm whenever feasible, but it is not always possible. Regarding the supposed flaws in the manuscripts, I think there are some very obvious ones which are going to be there in a retrospective study and very hard to overcome, like selection bias, referral bias, and there is no control group in this paper, which was what Dr. Lee was trying to do, was to select patients with uniform treatment. But I think would have been nice to have a palliatively treated cohort from the same institution to see the difference rather than comparing to a population-based database. I think it would be very nice. I think they have limited number of patients with mutational analysis, but whether RAS mutated or BRAF mutated patients have different outcomes in the context of chemoradiation would have been nice to answer with this uniformly treated cohort. We could potentially even envision a small case control study where RAS and BRAF mutated patients are matched stage to stage or with other clinical factors. Some obvious things like patients had altered fractionation, some patients had 3D radiotherapy, those were included, probably affects the outcomes to some extent, or at least toxicity to some extent. I think there is a small typo in the systemic therapy. The trial patients, it reads as if they received pazopanib and paclitaxel only for 2 weeks. But as Dr. Lee mentioned before, they received pazopanib and paclitaxel for the duration of the chemoradiotherapy. And I think this is probably the only cohort that we have available where patients have received taxane and adriamycin therapy, and it would be really nifty to compare these 2 regimens, because these both regimens are thought of as active regimens for anaplastic thyroid cancer. And we here at Mayo use both of them with radiation, but it would be nice to see if one is better than the other, so that we can move only one chemotherapy forward in the context of newer agents, which I will touch upon. Dr. Lee already mentioned anaplastic thyroid cancer is a double threat. It immediately presents a threat in the form of local asphyxiation from the tumor that is rapidly growing. And then immediately and in the near future, it also presents a threat of distant disease, which in most modern patients ends up being the cause for mortality. This is very well shown by these 2 statements that I picked out from a Canadian population-based study. In that study, patients who were diagnosed with anaplastic thyroid cancer but not referred for treatment for some reason had a median overall survival of 6 days. There is an NCDB paper where patients who were not treated with radiotherapy had a median survival of less than a month. And so there are obvious biases here, but I think any anaplastic thyroid cancer patient, I think, deserves some form of treatment or palliative measure before we send them home. And it would be cruel to send people to hospice straight from emergency room or a hospital. And if you look at Dr. Lee's paper, they had 23 patients with distant metastasis at diagnosis, but between the time of diagnosis and starting the radiation or undergoing surgery, additional 8 patients developed distant metastases, which speaks to the aggressive nature of this disease. So we not only have to think about local control, at the same time, unfortunately, we also probably have to think about what to do for the distant disease. There are many studies that have shown utility of chemoradiation over the years. I have picked out only 3 studies here from United States. All 3 studies used IMRT, and you can see the Mayo study, MD Anderson, and the present MSK study. There are obvious differences in terms of the fact that Mayo and MD Anderson study included palliative treated patients as well. Dr. Lee's study did not include those. The time periods are different, but what you can actually gain from this is the chemoradiation correlates very well with local regional control. And I think that's the goal of the treatment, considering the immediate threat that it presents to the airways and the structures in the neck. But patients still die. Dr. Lee showed you this distant metastasis-free survival graph from their cohort. This is from our cohort here at Mayo, and the median distant metastasis-free survival is identical. It is close to 6 to 8 months. So patients are still dying, even if we control their neck disease. They're dying of distant disease later on. But things are changing, and they're changing very rapidly, and I think I'm excited about that. You can divide ATC into 3 main groups, or at least I do so. BRAF mutated represent about half of the patients. The RAS mutated patients are 30%, and there is a very small group of patients which carry ALK, NTRK, RET fusions, or MMR deficiency. This is a patient that we treated in 2016, a gentleman who completed chemoradiation and then immediately presented with lung disease, and we treated him with dual BRAF and MEK inhibitor therapy, and he responded for a couple of years before eventually succumbing to the disease. Right after the MD Anderson folks presented a 16-patient study. So it's a phase 2 prospective study, and the results are phenomenal. The overall response rate in this study was 69%, and at this time the study was published, the median duration of response, progression-free survival, or the overall survival was not reached in this patient, which was unheard of for anaplastic thyroid cancer. These data led to the eventual FDA approval for dabrafenib and trametinib for anaplastic thyroid cancer that cannot be treated with surgery or radiation. And I don't know if there is any other disease where a 16-patient study led to an FDA approval for a drug. This has changed the outcome of these patients, like Dr. Lee already showed. There are very, very rare patients who also carry other alterations. This is a patient from the Libretto 001. In that study, there were 2 patients with anaplastic thyroid cancer, and one of them had excellent response to the LOXO 292. Now there is another selective RET inhibitor, Blue 667 as well, and both of them are FDA approved for any thyroid cancer that carries RET alteration or fusion. Similarly, you have case reports that have been published for TERK fusions, ROS fusions, and ALK fusions. And so in my mind, I think the next generation sequencing panel that looks for all of these mutations, or at least BRAF mutation, is mandatory when you have a diagnosis of anaplastic thyroid cancer. What about this big group, the RAS mutated? Unfortunately, these tumors don't have a very good targeted therapy, but there is some intriguing data. Dr. Kavani has presented this study at the ASCO 2020, which was unfortunately virtual, and I'm not sure if many people saw this, but it is now published. What they did is they treated their anaplastic thyroid cancer patients into 3 cohorts, BRAF, RAS, and non-BRAF. And I want you to focus on this RAS mutated cohort, where they treated with MEK inhibitor and immunotherapy, and the median overall survival was 18 months, which was phenomenal for this disease. Same time, there's a Novartis prospective phase 2 study with their PD-1 inhibitor or immunotherapy that shows 19% response rate irrespective of BRAF mutation, and overall survival is not as impressive, but 6 months in metastatic setting. And so it is tempting to speculate that the MEK inhibitor probably adds here to the immunotherapy. Well, all of these are in the context of disease that has been previously treated with surgery, radiation, or not candidate for those. Can we incorporate these treatments in a definitive setting? This is Dr. Bible's data that shows pazopanib induces paclitaxel-induced mitotic catastrophe, which led to the RTOG 912. Dr. Lee already showed you this slide, so I'm going to skip quickly, but what I would like to point out here is about 18 patients were ineligible for analysis in this study. This is a monumental effort, and I would have assumed the ineligible patients were because of wrong diagnosis, but they were ineligible because they could not get per protocol testing prior to initiating therapy, which is quite understandable because how quickly these patients progress, and we need to start the treatment. So when we plan our next trials, I think we have to think about that, and that might be one of the reasons why we did not see the difference here. But it is tempting to speculate that the pazopanib adds to the therapy because of the numerically higher overall survival. We also showed that PD-1 and PD-L1 is a predictive biomarker for ATC patients here at Mayo, and we planned a study and initiated a study where we introduced immunotherapy with chemoradiation, and we treated 3 patients, and here is the results from those 3 patients. There was very beautiful decrease in the mass very quickly within 5 to 10 days, but unfortunately all 3 patients died much sooner than we have expected from our past experience, and 2 of the patients died from pulmonary complications, and hence we halted the study permanently. But I don't think we should throw the baby out with the bathwater. I think we have to go back to the drawing board, and people are already Dr. Shah is planning, or actually already opening, a study with radiation and dabrafenib and trametinib combined together. Here we have not done that because of concerns for toxicity. So it will be interesting to see how this study pans out. It will be really nice to incorporate immunotherapy in a definitive chemoradiation setting for anaplastic thyroid cancer patients. I think Dr. Lee has a study where she's trying to do that in the context of SBRT and metastatic disease. I think what we need to focus on is how we can get the mutational analysis for these patients very quickly. Unlike other disease, we don't have the luxury of time. So we probably need to do this with a liquid biopsy or some other platform where we can get the testing within days rather than within weeks. MD Anderson folks have already published data very, very recently that shows that liquid biopsy correlates 80 to 90% with the tissue biopsy. And then, of course, we also need to focus on the mechanism of resistance to these treatments, including checkpoint inhibitors and the kinase inhibitors, because they do relapse eventually and succumb to the disease. I'm sorry I went too fast so that we have some time to go over questions, but this is the algorithm that we have published, which is not as comprehensive as Dr. Lee showed, but a little bit more simplified. And then, of course, please email me with questions. And thank you for your attention. And again, thank you, Dr. Brito, Arkin, and Dr. Lee. It was an honor. Thank you.
Thank you very much to both of you. This was really an outstanding discussion here. Nancy, very quickly, do you have anything to address in terms of Ashish's comments?
No, thank you, Ashish. That was so great. Thank you for catching the typo. I feel embarrassed. But you're
Oh, no,
absolutely
sorry.
right.
I'm sure when you publish the manuscript, I'm sure the RTOG will be that manuscript will have a correct. I don't think people will use that regimen based on this paper. They would probably refer to that paper, but I just wanted to point out.
Yeah, yeah, thank you. Yes.
Nancy, there's a question regarding whether you use quad shot for BRAF mutated patients to maximize their time on targeted therapy. What's your protocol in patients who are started on a BRAF and MEK inhibitor and then undergo radiation?
Yes, thank you. So we would, again, like the patient I show, that you would continue on the drugs, and then if they can go for surgery, go for surgery, and then we would do quad shot twice a day for 2 days. I really think that's better than 60 gray, because you can carry the dose and get an equivalent of 60 gray, and then in between the cycles to give the 2 drugs, the targeted therapy, because we have the battle, as she said, about distant metastases. So it's like you have to get local regional control, then you also have to battle to make sure they don't fail distantly. So that's really the protocol. But I'm putting that protocol together because, you know, we haven't used these drugs concurrently with quad shot yet. I've done it with taxanes, we've done it with Adria. We have no problem. I'm medical oncologist, no issue with chemo and quad shot. It's just not with these 2 drugs yet. So we want to put on protocol.
Great. And, you know, one of the big questions that always comes up and is related to the extent of surgery. And I did not see a analysis of R0 versus R1 in your patient population. If I missed that, I apologize. But can you speak briefly to that differential and what your thoughts are? Because obviously it relates to both the disease, but also to the extent of surgery that's required.
Yeah, it's a very hard one, at least in the retrospective study, to really tease out, Mark. The people that had R0 resection always did best because you're not dealing with microscopic disease. And then the people that fail immediately or that had R1 resection, it's complex because we also change our dose of radiation, sometimes that boosts higher. So at least in local regional wise, it seems to do a little bit worse, but then we battle with the distant metastases, right? So there's a lot of confounder. All I can say is that, I can definitely say trimodal therapy is the most important, meaning a good oncologic surgery, not like a biopsy. So surgery is important. And then whether maximally get it to R0, sometimes you just can't get down to R0. You can only do R1. And is that wrong to do? No, I think that still is helpful. But I don't think we could statistically show a difference because we also did other things to boost it. But I think, you know, volume is important too. I hope that
And
answered.
I will add to that. I think, Mark, it is very important to understand that you as a surgeon could probably always get a R0 margin if you undergo tracheal resection or anastomosis in esophagus. But I think time is of essence here, and we don't have the luxury of having 4 to 6 weeks like we do in head and neck squamous cell carcinomas to start the adjuvant treatment. And so you want to avoid any big surgeries like that is going to delay the adjuvant treatment. So it would be okay to do an good R1 surgery rather than trying to do a R0 resection with anastomosis that is going to delay the adjuvant radiation.
So obviously that question is most significant in the patient with stage 4B disease versus 4C. But and so the question becomes, in the patient who's got disease extending into the trachea or the larynx and no evidence of distant mets, not taking those organs would lead to an R2 resection or no surgery at all. So how do you balance that and in terms of the decision-making process? And I think you may have answered it, but maybe if you could address that specific cohort.
Nancy, you want to go? Or?
Go ahead, go ahead.
Okay, I think we here at Mayo have a multidisciplinary evaluation for the patient, and if the surgery colleagues think they are not going to be able to have a good surgery without doing any doing heroic things like that, like a tracheal resection or reanastomosis, then we take them to surgery. Otherwise, we go straight to chemoradiation. And that's why I think I kind of wrote in my note that chemoradiation is the cornerstone here, rather than surgery followed by radiation or chemoradiation. So we take that approach where if, and sometimes there are surprises when we think it is resectable with R0, you go in and we find out that it is not. In those patients, I think it is okay to have a R1 or R2 resection, but initial evaluation, if we think they are not going to be, we usually don't go that route.
Yeah,
Right.
similar. I have to say that we wouldn't be taking those organs out because then that's when we go to chemoradiation.
Okay.
It isn't that we always never, like, you know, but anyway, yes, it's 9:01. Sorry, you said hard stop.
Yeah, I'm going to give you one last question. Maybe each of you can address this very quickly. This is a disease like none other, and certainly the recent ATA guidelines do indicate the depth of the decision-making process. And the ATA guidelines included an ethicist as well as patient advocacy groups in their recommendations here. In light of the speed to initiate therapy and all of the other factors, who's involved in providing counsel to the patient in each of your institutions in those first 72 hours where you're rushing to establish a plan of care?
We have like what I call the 1-800 hotline. It's called Sherman Lee hotline. So, and then the surgeon as well. All three of us discipline, we will all see the patient immediately the day of diagnosis, and we ad hoc clinic. And then all of us will talk within each other first and then present a uniform message to the patient, because otherwise it would be very confusing for the patient. So that's our approach.
Great. Ashish?
We do almost exactly same. We see them the same day, most of the time very next day, and there are a few of us who get together and then present uniformly to the patient. The only other additional thing that we possibly do is we include palliative care in our initial discussions as well. Because unlike most of the other institutions, we do paclitaxel and doxorubicin both, and unfortunately most of our patients have significant pain, mucositis. More than half of the patients get feeding tube temporary, so we involve palliative care folks in the initial discussion as well.
Great. I apologize to all of the people who have sent in questions that I've not been able to get to. We do have to stop at this moment, and I apologize. Again, a tremendous thank you to Ashish and Nancy for your incredibly wonderful presentations, and Nancy for putting that manuscript together. And we look forward to continuing this discussion in the future. Thank you, everybody, for joining us. I hope that you will tune in again next week. And everybody stay safe, and look forward to joining us again here. Thank you.
Okay, thank you. Bye-bye.
Thank you.